Good evening, everybody. I'll be presenting on the early versus the late presentation of aggressive posterior retinopathy of prematurity. I have no financial disclosures for this talk. Retinopathy of prematurity, as we know, is a disease of the immature vasculature of the premature infants. It is essentially a man-made disease as it came after the ventilators came, and smaller and lighter babies have started surviving. Effective screening and early treatment are the only proven tools in the hand of the ophthalmologist to prevent blindness in these children. The Indian guidelines, the National Neonatology Forum, and now more recently the Rashtra Bal Suraksha Karyakram have given us the guidelines for the weight 2000 grams and the age of the child 34 weeks. But it is more important that when we screen these children, for when we screen, the guidelines that are given is not to delay the first screening more than 4 weeks, that is 28 days of life. That is the dictum that we take. However, early screening has been recommended for infants who are born less than 28 weeks or less than 1200 grams of birth weight. So they have to be screened at 2 to 3 weeks instead of 4 weeks. The characteristics of these early presenting children are largely unknown. The aggressive posterior disease that presents in these children are unknown. And we also know from our study done from our center that babies with weight even more than 1250 grams develop severe ROP in our country. So our purpose was to report the disease spectrum and the treatment outcomes in early versus the late presentation of aggressive posterior retinopathy of prematurity. It was a retrospective chart review of all the treatable ROP eyes between January 2002 and March 2017 at the retina services of our center. We divided the AP-ROP eyes out of those eyes into two groups: early presentation less than equal to 28 days of life and late presentation more than 28 days of life. The records were evaluated for the demographic characteristic, risk factors, presenting features, mode of treatment, and also the treatment outcomes. AP-ROP was further divided into the two presentations that we know: the classic AP-ROP of flat neovascularization, posterior disease, and significant plus disease, and the hybrid ROP in which the classic disease coexists along with some intermediate stage. Outcomes with the laser treatment as defined with success if there was regression with or without sequelae and attached posterior pole. Infants with incomplete documentation and less than 3 months of follow-up after treatment were excluded. The statistical analysis p-value of less than 0.05 was considered significant. So 430 eyes of 224 infants were treated for ROP during the study period, and 235 of these eyes met the inclusion criteria. That is, they were diagnosed as aggressive posterior ROP. And as we can see, almost 40%, 93, I'm sorry the other figure is not coming, 93 or 40% of these eyes had early presentation of AP-ROP. The age at diagnosis on average in the early presentation was 25.6 days, and in the late presentation was 44 days. What was surprising here was the birth weight of these children. The average birth weight in the early presentation group was 1300 grams, which was statistically significantly higher than the late presenting group that was 1193 grams, which is totally converse to what our guidelines say for early screening of 1200 grams. The gestational age was also significantly higher for these children at 29.7 weeks compared to the 28.4 weeks for the late presentation. The earliest treatment that we did was at 17 days of life. The diagnosis, the early presenter had more of classic AP-ROP-like picture, while the late presenters had a hybrid kind of picture predominantly. The location of the disease was by and large equivocal in both the groups. However, posterior zone 1, in which the vessels are not even reaching up till the fovea, was more present in the late presentation group rather than the early group. When we take a look at the risk factors, all the risk factors that were possible to be considered were considered. However, only multiple births was one of the risk factors which came in for the significant development of early disease in these children, except for the birth weight and the gestational age. Similarly, for the presenting features, when we see the early disease presents with more of a subtle presentation with avascular loops, while the late presentation presents with more of flat neovascularization along with fibrovascular proliferation which pulls up the retina. This is a representative picture of the early group in which we can here see the loops that are present in the posterior pole and also the dilated plus disease that is present. This is a classical AP-ROP-like picture. While in the late presentation, we can see this fibrovascular proliferation tissue that is developing, and along with these hemorrhages and the more posterior presentation of disease in the late group. The treatment outcomes with the standard of care, that is the green laser treatment, were acceptable in both the groups and comparable. So with good treatment, both could be treated well. So to conclude, heavier and more mature babies are developing APROP in an early stage in our country. Such patients have a more subtle presentation with avascular roots and need to be looked for more carefully in the absence of fibrovascular proliferation. This has implications for early screening guidelines for ROP, which is a major flaw in our current guidelines, which gives it at 1200 grams, and an average what we got was 1300 grams. And higher birth weight infants are developing APROP. Thank you.
Question, in your series, which is the highest birth weight of the child who got the
2500
ROP?
grams.
How much?
2500 grams.
Oh.
So you prefer to treat with laser or you prefer anti-VEGFs also?
By and large, we prefer laser, sir, wherever it is possible. Wherever we have a view, we do the laser. Only for posterior zone 1, where sometimes the vessels are not even reaching the fovea or the pupil is not dilating even with indentation due to the tunica vasculosa lentis, do we go in for an anti-VEGF, and we always supplement with a laser and not alone anti-VEGF.
Okay. Any specific reason why there is a early presentation and late presentation? Just that they couldn't come to you, or is there any other specific reason?
For the early presentation or the late? Ma'am, by and large, most of these children were referrals and from our nursery. So what we advise, at least in our surrounding, is for a screening to be done at around 3 to 4 weeks, and also when they discharge the kid from the special newborn care units that are present. So whenever they are discharged, they are just sending us for a referral so that the patient gets sensitized that they have to get screened for ROP. That is how we were picking up these children early, rather than if they would have followed the guidelines, we might not have picked them up that early. Thank you.